Good day. I'm Dr. Kayser with Image by Design Plastic Surgery, and I want to invite you to a short little discussion about implants. This is a very popular procedure, certainly in my practice, and I thought it was helpful to kind of review the basics of what implants are. Patients always have a ton of questions on why we choose certain implants and what implants are available. So I wanted to kind of review everything, and we've got a large selection of implants here. Implants come in all sorts of shapes and styles from different manufacturers, and in the United States they're all FDA approved and they're all good. We've got Saline and we've got Silicone. For many years the Saline was the only implant available except for special circumstances, and they actually did fine. It's the same outside elastomer shell that all the silicone implants have, except this is filled with salt water. Many patients like the Saline implants because they want to know when it leaks, and this implant will make it clear when it leaks. This implant is not pre-filled. It's inserted usually through a smaller incision site, so that is an advantage to using this type of implant because the scar is smaller. The implant, however, because it's filled with saline, tends to be a little bit more ripply. The final implant doesn't have air like this one does. It is filled completely with salt water. Silicone implants have the same outside shell. It's the inside that's different. The inside is filled with silicone. These have evolved quite a bit since their early production decades ago. Two things have changed. First, the content of the silicone molecule, which in the old days was very syrupy, has become much more cohesive or sticky. And the reason for this is that because the individual silicone molecules now have cross-linking between them, which can be adjusted to also change this cohesivity of the silicone gel. If I cut into this implant, unlike the old syrupy silicone, this tends to stay sticky. So if I look over here, I can see that this implant, which has been cut, doesn't leak. I can push on it and the gel material is still cohesive. And this is a good thing. We've come to realize that the cohesivity has made a big difference in these implants. The gel material, however, inside is oily. And the other problem that existed with the previous generation implants is that the oil would permeate through the membrane. So what they've done also, in addition to thickening up the membrane, was to make it impermeable to the oils that naturally want to leak through. So I can leave this on the table, I can pick it up, and there's no film as we used to see. So between changing the silicone consistency or cohesivity and thickening up and making impermeable the membranes, we have much better implants today. These are reliable devices. You can pretty much do anything you want with them, to any of them. With silicone now, if this is ruptured or leaks, patients can go months or years without knowing it. So a couple things to remember about implants. One, they are man-made devices, and because of that, two things will happen. First, they will eventually leak. The average lifespan on a saline implant might be 12, 13 years. And like I've said, when this leaks, you know it. With the silicone implant, this cohesivity likely leads to a longer lifespan. And when we increase the cohesivity of an implant, we can actually affect its stability to the point where it can maintain shape. The other thing that will happen with an implant, in addition to the possibility of leak, is that your body will naturally form scar tissue around it. This scar tissue layer is called a capsule, and it's normal. However, this capsule can change for many reasons that are not completely understood. It can get hard, it can deform the implant, it can change the shape, it can even cause discomfort. This is called a capsular contracture and is one of the reasons why women do require removal and or exchange of the implant. The good news about silicone is that we have shown over and over that these are safe devices. And in 2006, the FDA was able to look at our data and finally approve these implants. And so for 15 years, when we only had saline, we now were given the opportunity to use silicone implants in cosmetic patients. This has changed everything. Patients now, almost in my practice at least, universally choose silicone devices. These are smoother in feel, more natural, tend to ripple less than the saline implants. They are more expensive, and that is one of the reasons that women sometimes will choose saline implants. The next topic has to do with the cohesiveness of the implant to the point where we can actually change its shape. And if you look here, you can see that these implants are round, but they are deformable. If we increase the cross-linking between the molecules, we can actually make the implant more rigid to the point where it actually maintains its shape, and we can develop what is called a profile or anatomical implant. Because of this, we can end up with the typical round footprint, or a flat, wide footprint, or a high footprint, and we can also change the projection of the implant as well. Of course, we can maintain a round implant device just like the smooth textured implants have. It's important to understand too that if you have a shaped device like this, it has to necessarily be textured so that the implant does not flip. Even under certain circumstances with texturing, a textured device, whether it's made out of silicone or saline, because these come in texture also, can flip, and that can create a visible irregularity that patients are not happy with. Finally, when you look at these different implants, you can see that they have different projections, different fills, different diameters. And all these characteristics are used to properly fit an implant with each specific patient's breasts. And even that can vary from one side to another within the same patient. So if I have a very small woman who wants to be small, I don't want a high projecting implant. I might even go to something smaller that would allow the diameter to match the width of her breast. I don't want an implant that's too wide, and I don't want an implant that's too small. If that same patient, however, desires to be much larger, I'm going to want to tend to maintain the base width or diameter of that implant, but increase volume by adding projection. And so by doing that, I can increase volume and still maintain the same diameter that we've got here. Each implant is ideally suited for each patient. I don't think that there is any right or wrong answer, and these are questions that are thoroughly discussed during my consultations with each of my patients when they do come in for breast augmentation. We have an opportunity to talk to each of our patients, determine what they want, where they start, where they want to end up with, what type of breast they have, the coverage of the breast tissue, whether or not they desire to have a saline or silicone implant. We then fit each patient and invite them, of course, to come back and be refitted. Our goal here is to ensure that each patient comes back and is completely happy with the style and the implant that they've chosen. Again, there is no right or wrong answer with this. Certain patients do well with an anatomical. In my experience, however, the difference between these two is often not that significant. And there are studies that actually show that if I were to put one implant versus another, it would be difficult to even tell the difference. Implants do change, they can deform, and so my goal is also to make sure that my pocket is accurately dissected and created in a bloodless approach that helps minimize the risk of developing abnormal scar after surgery, and also minimizes the discomfort after surgery. My patients generally are off their narcotics in a day or two, are able to take their dressings off the next day, and are able to shower the next day. Most of the swelling is gone within 5 to 6 weeks, although as the weeks and months continue to progress, they do see changes. And usually between that 9-month, 12-month to even 2-year time is when that natural feel and look and motion of the breast occurs. Scars are almost virtually undetectable, especially when placed in the fold. For the most part, this tends to be a well-placed scar. Scars can also be placed around the areola, within the armpit, and the transumbilical approach. The use of a saline implant, because it is not pre-filled, allows the use of a smaller scar versus a gel implant, which tends to be a little longer. And for the hypercohesive or gummy bear implants, which have more rigidity to them, requires a longer scar to be placed. So these are factors that come into play as well. Virtually all of my patients have implants placed under the muscle. I perform what's called a dual plane approach, which means that there is a mild separation of the muscle and skin at the lower pole or bottom of the breast, with release of the muscle so that the implant can properly descend and drop into the breast. The tissue characteristics, the size and shape of the breast, the development of the breast, all can play a factor into the size and shape of the implant that is chosen and the end result. I want to thank you for being with us today. I invite you to contact us should you have any questions, and I certainly look forward to meeting you in the near future. Thank you and have a wonderful day.